So we're going to just chat a little bit about dementia today. I figured that would be a pretty good topic. Most people have questions about it and want to learn about it and hear about kind of what's new and what we know. So we'll start there. And then kind of toward the end, we'd love to just tell you guys about our project that we have, Bloom Homes. But I'll go ahead and get started. So I'm a geriatrics professor at the university, and I'm also a clinician, meaning I see patients at the clinic. So that's where I was this morning when I felt naked, and that's where I'll be going back. I've got 3 more patients to see this afternoon. And I really love this cartoon. You know, as physicians, we always tell you to, eat clean and exercise and do all the things, sleep well, and then so that you can live forever and be healthy forever. And, you guys all seem like you're in very good shape. However, some of our patients aren't. And so this is kind of a satire, I guess, satirical cartoon. Okay, so I just wanted to show a diagram of the brain and just show you guys very briefly all the different regions of the brain. So as y'all know, the brain does everything that we need. It keeps us alive, it helps with our functioning, it helps us think, remember, love, care about people, and all those things. We won't go through all the areas, but I just want to show you this to show you how complicated it can be and that some of the regions overlap as far as their functioning. And that'll be important when we're talking about the different dementias. This slide, I think, is probably the most common. I get most questions asked about this information. What is the difference between normal aging and dementia? And so I like to, if I didn't have something in my hands, I kind of draw a little imaginary spectrum. And I like to say over here we have normal aging. So it's normal as we get a little bit older to be a little bit forgetful. It's normal to walk into the kitchen and forget why you went in there. Normal to leave your bag somewhere and forget where you left it. But at this stage, you're still doing all the things for yourself that you would normally do. So you're still paying your own bills, managing your own medications, and so forth. So it's almost like the brain, oh, thank you, whoever, thank you. That way y'all can see things a little bit better. I forgot to ask for that. See, I forget things too. And so, but basically, if you forget these things, usually in normal aging, you're going to remember them later. So later you'll say, oh, you go back out from the kitchen, you retrace your steps, and then you remember, oh yeah, that's why I went in there. And so it's actually very normal to do this as we get a little older, even in our 40s. It's kind of like our brain is just slowing down a little bit. There's only so much that our brains can hold, right? And then on the opposite side, we have what we call dementia. So that's enough trouble with your memory or your thinking. It's not just memory. It can also be other things like language. And that's why we kind of lump in memory or thinking, because language has to do with the way we think as well. It's enough trouble with some of those functions that it does impact your daily functioning. So maybe you are having a little trouble paying bills. Maybe you are having a little trouble remembering which medications to take when. Again, being a little bit forgetful about that here or there is not a big deal and can be considered normal. But if you're forgetting those things on a more consistent basis, and basically just kind of being a little more disorganized, then that's when we start to worry about dementia. And then in the middle of those 2 extremes, we have something called mild cognitive impairment, or MCI. That's where you're going to be a little bit forgetful, but maybe a little more than might be expected for your age. So maybe you don't remember why you went into the kitchen, even after retracing your steps. Maybe you don't remember at all where you've put your bag. Again, don't worry if that's you and that happens occasionally. But if it's happening more frequently, then we're going to start to worry that there may be some concern there. Mild cognitive impairment, our patients in this category are still functional. They're still paying those bills. They're still driving. They're still taking their medications correctly for the most part. It does not necessarily progress to dementia. For some people, it can be the first sign of dementia, but not everybody. I think the last statistics I read were about 15% per year do progress to dementia, but that leaves 85% that do not. I will also say that mild cognitive impairment can also be caused by other things. Perhaps somebody's not sleeping well. Perhaps they have an emotional stressor in their life. Perhaps they're depressed. Perhaps they have undiagnosed sleep apnea. There's a lot of different things that can cause sort of a mild impairment that actually, if we figure out the reason for it, we can improve by treating it, and they can go back to the normal aging category. So I like to say that. I find that very helpful and hopeful. And so how do we diagnose dementia? We just said enough trouble with our memory or our thinking that it impacts our functioning. But a little bit more in depth, you have to have deficits in at least one cognitive domain. So our major cognitive domains are these 5 domains: memory, verbal skills or language, so maybe trouble understanding language or even trouble speaking it. Performance of tasks, which is also called apraxia, so maybe remembering how to operate the remote, for example, or how to fill up a gas tank. Recognition of familiar things, so if somebody is not really sure, that this is a bottle, or they're not sure, that this is a phone, just kind of recognizing those common things. And then also planning and abstract thinking. And that kind of has to do with what we were talking about earlier with driving, taking your medications, planning your bills and budgeting and things like that. So that's kind of the organizational part of the brain. And then it must also not be delirium. Does anybody know what delirium is? Okay. I just didn't want to talk at you. I was trying to get y'all engaged a little bit. But it's okay if you don't know. So delirium almost looks like dementia, but it's a more acute or immediate onset. And we usually see it in our patients that are in the hospital and they suddenly, maybe after surgery, they don't know where they are, or they don't know who their family members are. It's a very acute, rapid change. Dementia itself is usually more of a slow decline. So that's kind of the difference there. The good news about delirium is it can be reversed in most cases. So most patients, give them a couple of days and the anesthesia will wear off and then they're going to be a little bit more oriented. That's not always the case, but just speaking in generalizations. And we do see that commonly, especially in the hospital. But also just having the UTI can cause delirium, maybe a medication change, or maybe not having the appropriate medications and so they're withdrawing on some level, even if it's not an addictive substance. There's a lot of different things that can cause delirium. So Alzheimer's disease is going to be our most common form of dementia. I like to say dementia is an umbrella term, and underneath it we have several different types. So Alzheimer's is the most common type of dementia, but not all dementias are Alzheimer's. And this is going to be basically somebody who's typically in their 70s, 80s, 90s, and they've kind of had some memory loss, particularly short-term memory loss that's been going on for a long time. And then it slowly starts to impact their functioning. It's not something rapid, it's not overnight, it's typically very slow. And again, we want to rule out these other causes. So if somebody comes to see us at the Mind Center and they want a dementia evaluation, one of the first things that we do, we want to rule out any other causes. We don't want to diagnose dementia if we're not sure. We want to make sure it's not delirium, make sure it's not a medication issue, make sure their thyroid is normal, make sure their vitamin levels are normal. There's a lot of different things. Psychiatric illnesses, depression, anxiety can present as forgetfulness. And then of course things like tumors or an infection in the brain. And so we're typically going to do a brain scan, a CT, or an MRI to rule those things out. We're also going to get some lab work to make sure nothing else is causing this. Looking at things like thyroid. And so under that umbrella, we have a few other major types of dementia. There's actually over 20 different types, but most of them, luckily, are very, very rare, so we're not going to go through all of those. But vascular dementia is going to be our second most common type. And then, well, actually, to me, it might be between vascular and mixed. So a mixed dementia can be 2 or more types coincide, like happening at the same time. And often we'll see a patient who maybe has a vascular dementia, which is a type of dementia from having had a stroke. So whatever stroke, wherever that stroke happened in the brain, that's going to be the area that's affected, and it can impact your functioning. But oftentimes I see a mixture of those two things happening at the same time in somebody. It's kind of difficult to diagnose sometimes because there's a lot of overlap with symptoms and things like that. And then luckily we have 2 others. They're more common than some of the super rare ones that we won't talk about today, but they're still pretty uncommon, luckily. And that would be the Lewy body dementia and the frontotemporal dementia. And we're going to talk about what those look like in just a minute. So we've talked about vascular dementia and how it can happen from having had a stroke. But there's even some mild changes that can happen in the brain over time, like damage to your blood vessels. That I think in 10 years or so may be classified as part of vascular dementia. And so if I have somebody come into my office and maybe they look like Alzheimer's, slow, gradual progression, but they also have a lot of damage to their blood vessels on their brain scan, but no stroke, I'm just kind of thinking, okay, it may be sort of vascular, they've got vascular risk factors anyway. They haven't had a stroke, but I think in a few years that will be included in the definition. And these patients may have trouble with their walk or their gait, and they may also have Parkinsonism, which is not Parkinson's disease. So Parkinson's disease, of course, is the resting tremor, somebody who has trouble kind of getting started walking. But Parkinsonism can look a lot like that, but it's not from the same problem in the brain. Parkinsonism can actually be from having had different problems in the brain, or even certain medications can cause Parkinsonism. Very, very interesting and complicated. So you guys know who this is. Sometimes I give this talk to medical students and they have no idea who this is, and I'm always really sad. So I'm sure you guys know Robin Williams. He actually, does anybody know what type of dementia he was diagnosed with? Somebody said Parkinson's. It's similar to that. He actually had Lewy body dementia, which can look a little bit like Parkinson's because they do sometimes have the tremors and the movement disorders. But Lewy body is actually really tough because it happens younger ages, usually 50s, 60s, 70s. They can have trouble with the gait and the movement, like we said. They can also have a lot of trouble with their sleep and their mood. And we're also going to get things like hallucinations very early in the course of disease. And what's really sad is oftentimes with Alzheimer's patients, they don't know they have a problem with their memory, but our Lewy body patients are actually mostly aware of it, at least at the beginning, which, as you can imagine, can cause a lot of psychological distress. And I think Robin Williams actually ended up committing suicide, probably because it was such a difficult disease to weather. And so if we see a patient who has a lot of hallucinations early in the course, but their memory is still relatively intact at the beginning, we're going to think about Lewy body dementia. It is a faster progression. Patients don't live quite as long as they can with Alzheimer's. Alzheimer's patients can live 10, 15, 20, 25 years. Our Lewy body and our frontotemporal dementia patients typically live 5 to 8 years or so after diagnosis, so it's much more rapid of a decline. Now, I know you know who this is on the left. Does anybody know who this is on the right? So, on the left, of course, we have Bruce Willis, and he's been recently diagnosed with frontotemporal dementia, and he originally had trouble with his speech, and so they diagnosed him with aphasia first, which is trouble with your speech. Turns out it was more complicated than just that. Over time, the dementia revealed itself. The man on the left is actually a man in his 20s. Very, very interesting story. I remember learning about it in school. His name is Phineas Gage. And this was back in the early 1900s, and he worked on the railroad. And I don't really know what that means. It's hard for me to imagine. But I guess there was some kind of a tamping iron where he would kind of tamp down what sounds a little like gunpowder. And it ended up blowing back up in his face, and the spike actually went through his eye and through his brain. And it actually went through the frontal temporal regions. And so he was kind of one of the first people to exhibit some of these symptoms that we now see in older people who this happens to just through degeneration in those regions. Pretty interesting story. He used to be very kind and gentle, apparently, and then after the spike happened through his brain, he became a wild womanizer, drinker. He was angry. His whole personality changed. And so one thing with our frontotemporal patients is that their whole personality can change. And typically it's somebody meek and mild-mannered that maybe becomes more aggressive. But I still remember in fellowship I had a patient in his 50s, which of course is scary. I'm 48 and that's right around the corner. He was in his 50s and he had always kind of been a loner, very quiet. But all of a sudden, and just kind of not affectionate, and all of a sudden, all he wanted to do was be by his wife's side, and hold her hand, and she said, I love the new affection, but to be honest, this is just not his personality. And so that's kind of how we knew something was going on with him. And so, what is the role for drug treatment? Unfortunately, we don't have any cure for any kind of dementia. We don't have any way to reverse it, unless it is one of those reversible types, meaning thyroid And sometimes if we treat those memory difficulties by treating the underlying cause, those patients do get better. But dementia itself does not get better, unfortunately. There are some really, really smart scientists at the university where I work working on cures. And we do have some options for treatment, but nothing is a cure yet. And so I will say these medications you probably have heard about, Aricept and Namenda, those can be helpful. What I've noticed is in about a third of my patients, they can kind of help with function. It's almost like, because we used to think they were changing what was happening in the brain, and it turns out it's not slowing it down. The degeneration is still occurring, but it's almost like these medications, neurochemically, they're kind of masking the symptoms for a little bit longer. But I've only seen it be beneficial in about 30% of patients. The other 30%, we don't notice any difference, and then we just take them back off of that medication because, of course, it can cause side effects, interactions, and so forth. And then the last third of my patients, I would say, maybe there's a reason we can't start that medicine because we're worried about a side effect or they have some contraindication. And so it's only modestly beneficial. You know, I have a lot of people come into the office wanting a miracle cure, and gosh, I really do wish I had that for them. But unfortunately, these are kind of the things that we try, and if they help, excellent. If they don't, we don't have anything really better yet. So this is just a little chart, and I'll be happy to share the presentation with those of you that are interested. We're not going to really go through this because this is a lot of detail that you may not need or be interested in, but if you are, you can certainly refer back. These are just a list of those medications that I've mentioned, and there are a couple more in there. The donepezil, galantamine, and rivastigmine, the top three, those are all in the same drug class. The memantine is in its own class, and then at the bottom there's a combination pill that they make. But of course, it's more expensive. So what we do, if we feel like somebody warrants both medications, we'll prescribe them separately, and it's a lot cheaper. Now there are some new medications on the market. They also don't cure it, they don't reverse it. However, we think maybe in some people they might slow it down. And so these are going to be the Leqembi, Aduhelm. You've probably heard of lecanemab or aducanumab, maybe in the news or something like that. These are monoclonal antibodies that you actually have to take IV. So they're infusion every 2 weeks, which is kind of a pain in the butt. And then you also have to have regular MRIs to make sure there are no side effects from the medications that are happening, because these medications are known to cause brain bleeding and brain swelling in about a third of people. And of course, if you've already had a stroke or something like that, we don't even want to start that medicine because, of course, that could increase your risk for having another. But this is really interesting. Nobody really knows what causes Alzheimer's, and that's what these medications are for. Unfortunately, there's not as much research being done on the other types of dementia, but I also think that will change in the coming years. But as far as Alzheimer's, we think it's due to the buildup of these plaques and tangles in our brains. Nobody's even sure about that. We don't know if that's the cause or if those plaques and tangles are actually caused by some other mechanism that causes the brain cells to destroy themselves. But what this medicine does is it literally targets those plaques and tangles and kind of cleans them up out of the brain. So while it can't reverse any damage that's already been done, they think in some patients it can slow down the continuing damage, which could be really great and sounds really great in theory, but in practice it's actually not that helpful. It doesn't seem to make a huge difference, except in a few people. There are a few people that it does seem to help. But again, we're kind of arresting it. We're not able to reverse it or regain some of those brain cells, unfortunately. But I hope by the time it's our turns, or you guys' turns to have dementia, there will be something better out there for us. We're certainly hopeful for that. And so what else might we do? So we do have those memory medicines we talked about that are only modestly beneficial. But with dementia, unfortunately, in a lot of patients, we see a lot of behavior issues. People become aggressive, they're hallucinating, they're confused, or they're angry, they're upset. Some people have trouble with their sleep, continence, and things like that. There are some medicines that we can prescribe that can help with some of the symptoms. So again, we're not treating the dementia, but we are treating some of the anger, the sleep difficulties, and things like that. So some of these antidepressant medicines that I've listed here, they do help with depression, but they can also help with mood in our dementia patients. And also also, depression is very common in our dementia patients as well, because as you can imagine, the regions of the brain that control emotions and depression can also be affected. So as you can imagine, they can kind of go together pretty frequently. Another thing we might prescribe would be the antipsychotic medications. Those are going to help with hallucinations. As a side effect, they make people drowsy. So if I have somebody that is hallucinating and not sleeping, I might try this medicine. Because one medicine that does both is better than two medicines that could potentially interact with each other and so forth. And then of course we have some mild sleep aids that we can try as well if somebody is having trouble with that. And these next sections, I have several slides. I'm just going to kind of go through them quickly. But again, y'all can review this presentation later. The main thing here is how do we address the behaviors without medicine? You know, we do have those medication options, but if there's a way to address it without doing medications, that can minimize our risk of side effects, interactions with other drugs, and things like that. And there are often some ways that we can behave and learn to communicate better with our dementia patients and loved ones. And so one big one is distracting them or redirecting. It's very common for a dementia patient to not recognize where they are and say, I want to go home, I want to go home. And maybe they even pack up their bag every night. Or maybe they're in the car and they don't recognize where they're going, so they jump out of the car. I can't tell you how common that is. And so one of the best ways to do that is to distract them. You know, if they're not in the car trying to get out actively, that's more of an emergency. But if there's somebody saying, I want to go home, I want to go home. I actually had somebody tell me this, a caregiver. She said, you know, Dad says that every night. And luckily, she doesn't have to work right now, so she's able to spend a lot of time with him. I know it's a much bigger burden when you, as a caregiver, also have to work, or you also have children you're taking care of. But she actually, and I don't remember if she retired or quit her job to be with him, but she was privileged to be able to do that. And so every night, she'd say, okay, Dad, let's get in the car, we'll go home. So they get in the car, they pack up their stuff, they get, you know, they go driving, they go out of the neighborhood, and then they start to kind of circle back. And she said the whole time they're kind of chatting with each other. They're telling each other stories. You know, he's reminiscing about the past, and she's asking questions, and it's a really good time for them to bond, which I thought was really, really a neat way to kind of reframe. Because honestly, if it were me and I didn't know what I know now, I think I would be really irritated by that. And I'd probably end up yelling at my loved one. You know, and that's not something that you want to do because one, they can't help it. Two, it doesn't make things better. And so we really have to meet them where they are. That's kind of the bottom line on all the behavior stuff. We have to meet them where they are, try to figure out if there's something that they need. So back to my lady, so they would drive around, and then all of a sudden he would start to notice landmarks. He'd say, oh, that's the gas station by the house. Or, oh, that's our church. And she'd go, yeah, see, we're getting home. And then by the time they got home, he recognized it because he had so many landmarks along the way. And then he was comfortable for the rest of the evening. And unfortunately, you know, I think he would kind of do this every night or every other night, so it was an ongoing thing, which is difficult. But I really admired her patience and her way of reframing this and turning it into something positive for them. So there are ways to do that. That's an extreme example. I have other patients who don't want to take their medicine. And they say, okay, you know, well, let's eat some food, and then they'll eat some food, and then they try the medicine again, and they're able to get it down because the patient has already forgotten that they refused their medication. So sometimes we just need to focus on something else for a little while and then come back to whatever it is that we're trying to have them do. I put some things like having photos of family members. Typically the longer term memory is intact for longer than the short term memory, so reminiscing, going back to the old days is very important. We put things like heat lamps in bathrooms. Another thing that's common is our dementia patients don't often want to shower. And it's because typically they're uncomfortable or they have some need that's not being met, or they're afraid because they don't realize what's going to happen. And so just trying to make them as comfortable as possible. Have heat lamps in the bathroom. Maybe you have the towels heated. You know, a warm bath, not too hot, of course. And then maybe, you know, you cover the whole body with a towel, but then you just kind of expose the shoulder, wash the shoulder, cover that shoulder back up, and kind of do each body part at one at a time. You want to be as positive and respectful as possible. I'll go back through just a couple to make sure we highlight major things here. So communication is big. Like I said, arguing with a dementia patient is not worth it. It's just going to escalate the problem. It's going to upset them and you. Instead of saying, don't you remember this, Mom? Just say, oh, okay, well, there was this time that blah, blah, blah happened. And they'll say, oh, okay, making eye contact, making them feel comfortable with your language, have like an open body language. Sit down if they're seated, get on their eye level. Speak slowly, carefully, quietly. But you also want to make sure that shades are up during the day, there's some lighting. The whole day and night thing is very important because of sundowners. For whatever reason, our circadian rhythm is kind of set in stone, and our dementia patients get really anxious when night is coming. And so really just making sure our lighting is on track, make sure the shades are up during the day, make sure they're down at night, make sure our lighting is maybe just a little dimmer in the evening, and kind of get maybe some soothing music playing. There's a lot of ways to kind of help out with that agitation that don't involve medications. And I'm just going to kind of peek through and make sure I didn't miss anything very, very important. I put on here child-proofing. So one thing us geriatricians do not like is infantilizing somebody with dementia. So that just means, our patients with dementia are typically older. We don't want to make them feel like babies or infants, right? So we don't like saying things like diapers or child-proofing. We prefer briefs. Or, maybe safety proofing. I put child proofing on here because everybody knows what that means. But if I have a patient who's constantly trying to cook things and then forgetting to turn the stove off, you can get those child-proof knobs. There's child-proof locks and ways to keep drawers shut and things like that. You can also have life alerts if a patient falls so that they can contact somebody if they are alone for a time. Cameras can help you, make sure everybody is where they need to be and doing what they need to do. You also want to make sure that you're given good activities. A lot of times, patients are aggravated or agitated because they don't have anything to do. They're bored. And unfortunately, our brain isn't working as well, so they can't necessarily come up with something to do. So often, we try to help by giving people activities and making sure they're kind of mentally stimulated and with other people. I think that was my major points there. We've talked about, I'm going backwards. Okay, so real quick, I'm just looking at the time. Okay, I think we have plenty of time. So there are some considerations when we have a loved one with dementia. We want to make sure first and foremost they're safe. We want to make sure that the caregivers are doing what they're supposed to be doing, that a patient is appropriately supervised if they need it. We may also want to get their financial house in order. We may want to speak with a lawyer and see what we need to do, not just about wills and passing on money and objects, but about who's going to make decisions for them if or when they get sick and can't make them for themselves. And if we have a patient with mild dementia, typically they can still tell us what they would want in those situations. So as much as you can, involve them in that process. That's going to be really helpful. And then if they are ended up dying and you need to make some decisions, it's easier for you as a caregiver because you already know what they would want because they've told you, which is really, really helpful and kind of takes the guilt off of the caregiver. And then I put this in here, meaning making and spending time. You guys know as we get older, and I'm learning this in midlife, it's more important to me to make things meaningful than anything else. More important than any amount of money, or fancy car, fancy job, whatever, is spending time with my husband, my family, my friends, taking trips, doing the things that we enjoy. And one really good thing, and I lost my parents a little bit younger, but I wish now, of course, that I had that time with them to make those memories, to get that history from our family that I never got. And just spending time with them, they're still that same person. Of course, they're quite different in a lot of ways, but they're still that loved one, that you know. And so just spending quality time, even if it's somebody who's nonverbal, you can sit together and hold hands, just for them to know that you're there for them. It can be really, really helpful for them and for you to have those memories. And so one question that's really, really important to me is how can we prevent them? How do we prevent dementias? And so as you can see, the brain does shrink quite a bit because those brain cells are dying in those affected regions, unfortunately. So how can we prevent them? Long story short, we don't really know, but there are some things that we know that are healthy brain habits that you all can do now that I should be doing now. I do some of them. I'm working on it. Exercise is probably the biggest thing. And I know once we get older, we have some pains. Maybe we're using walkers or canes, but there are still some ways to be active, and there are still some good things that we can do. So getting that blood flowing, taking a walk if you can take a walk, just sitting on the porch even, moving from place to place, just getting active in some kind of way. And then maybe if you can, push yourself a little bit further every day. Maybe we walk to the mailbox for a week, daily for a week, and then the next day, maybe we walk to the mailbox twice. Maybe we walk around our sofa. Maybe we walk around the block. Whatever it is that you can do, and that's just walking, is just my one example. But I know too, they have those little pedalers that you can sit down and actually pedal on a bike. There's a lot of different options that people can do to get involved. Sit and Be Fit is a program that you guys may have heard of. And I imagine you'll have some exercise classes here. So I think I would encourage y'all to take advantage of that. And I need to do the same. I was just telling him I want to join the gym again. Literally on our way here. Okay, next would be healthy diet. And so we tried to do that with the salad, but then we kind of canceled it out with the chips. I'm sorry. But to me, it's about balance. If we can eat healthy 80% of the time, aim for 80% of the time, and then 20% of the time we have treats. That's going to be our healthiest diet. And we recommend the Mediterranean diet. So olive oil, avocados, nuts, beans, whole grains, fruits, vegetables, lean meats, and things like that. Just avoiding junk, avoiding things out of a box, avoiding the frozen lunches that I tend to take to work. Working on that too. Making sure you're getting good sleep is very important. And I know it's a little bit harder to sleep as we get older for a lot of folks. But just really try to keep a good bedtime routine. So try to go to bed at the same time every day. Try to wake up at the same time every day. If you do take a nap during the day, you've earned it. But try to keep it to an hour or less so that it doesn't interfere with your ability to fall asleep that night. Of course, no smoking. Limiting alcohol is very important. I had a patient in the office this morning, and she said, I'm having trouble sleeping, and my belly just doesn't feel good. And I said, okay, well, how's your diet? And she said, well, it might be those 3 beers I have every night. Okay. For the record, I like a beer as much as the next person, or 3. But we really want to limit it for females, and I see it's a mostly female audience. We want to limit it to 1 drink per day. That's going to be our healthy brain limit. And honestly, I think someday they're going to come out and say no amount of alcohol is safe. That's just my personal theory, as they did with smoking. But for now, 1 beer or 1 glass of wine or 1 shot, which is I think an ounce of liquor a day, is what they consider normal and healthy for the brain. No more than that. Remain socially active, and you guys are doing that. Y'all are all here together. And I imagine this is not your first time being here. Because I've seen everybody chatting with each other. Y'all know each other. You're being social. You've got community. I actually think that is probably the second most important thing, maybe next to exercise, as far as preventing dementia, because we are social animals. Even those of us that are introverts and loners, it's really important for us to connect with other people, communicate, keep those connections going in our brain. And we're social animals, whether we like it or not. And so it's very important to do those things. I have to remind myself that too after a long day. You need to get out of the house more. Puzzles are helpful. Reading is really, really helpful. More than that, if you have enough cognition to learn a new skill, that's going to be your best bet to create new connections in your brain and to strengthen your brain. So learning a new language, learning a new musical instrument. Maybe you've never been a gardener and you want to learn how to plant and take care of orchids. All of those sort of brand new, novel things are really, really important for brain health. And then making sure that you relieve your stress on a regular basis. And if you do have a more serious illness like depression or anxiety, get it treated. There's a lot of different ways to treat it. There's no one size fits all. And so I just encourage you to see your doctor about that. And say, hey, I'm not really feeling my best. Is there something we can do? And often there is. And this is just a really weird picture of our cat, Thelonious. He kind of looks like he's going to come kill us in the middle of the night. But I just put this in here so that people will remember. So that's kind of just a funny. He was a little baby then, wasn't he? Okay. So first, I don't know, should we talk about our project and then ask her questions? Okay.
Yeah, I'll talk about the project and then ask you.
Okay. So I'm going to ask you to come with me. So we'll talk